really, this is a schematic showing you what causes FH. And FH basically is an autosomal codominant condition. The predominant abnormality is related to the LDL receptor, functionality, the amount, that's about 85 to 90% of cases. But the docking protein that the LDL receptor recognizes is in the ApoB100, and if there are abnormalities or defects in that and that's not recognized, that means that you get defective clearance and therefore blood levels of LDL cholesterol are higher. And finally, the PCSK9 gain of function mutation, which basically means that you will reduce the recycling of the LDL receptor. So this is evident from birth. We can see in children within the first year of life, LDL levels of 240, 260, 300. And what it does, it's a bit like smoking and pack years, results in an increased cumulative exposure and atherosclerosis early in life. So if you have heterozygous FH, one abnormal gene inherited from one of your parents, then the average age that you might experience cardiovascular disease is in your 40s or early 50s. If you have two abnormal genes, then it's before the age of 20 compared to normal individuals. Now, this basically shows you the expected distribution of LDL cholesterols in normal individuals, individuals who are heterozygotes, and those that are homozygotes. But you'll see that there is some overlap because, and has been already been covered in one of the earlier talks, you get differences in penetrance, and you may inherit other protective genes which may contribute to lowering of cholesterol levels. So it's actually quite important to think about measuring cholesterol, because a lot of the clinical signs, arcus, tendon xanthoma, often represent more extreme cases or late diagnosis. The importance of early diagnosis is really shown here in men and women, where you look at the incidence of cardiovascular disease over time, and you basically see the widening of the event rate. So this basically means that with cumulative exposure, every decade that goes by that we miss, you are trying to reverse or slow down an increased burden of atheroma in the vessel wall. So identifying cases really has to reflect screening and has to basically start much, much earlier than we're doing at the moment. So how common is FH globally? Well, this is the totality of the global data. FH occurs with a frequency of about 1 in 311 individuals. Now, if you look at people with premature cardiovascular disease, those are general population. If you look at people with premature cardiovascular disease, it's probably overrepresented. The true number may not be 1 in 17, but certainly it's going to be a lot less than 1 in 311. So we can basically start to find these index cases by looking at our CCUs, looking at those people with premature coronary artery disease and high LDL cholesterol. But that's actually not what we want to be doing. We want to stop these people coming in the first place. It's common in all parts of the world. There are no regions of the world, whether you go to Africa, whether you go to South America, whether you go to the Asian subcontinent, the Indian subcontinent, or Asia, the prevalence is pretty much the same. And that can be really summarized also in terms of how FH is detected and managed in the FH Studies collaborations. There are now over 70 countries and over 70,000 cases that we've put together. And essentially globally, the average age of diagnosis is 44 years. That means we've missed 40 years of exposure. So that means by that time, you've got to be a lot more aggressive with your treatment. And these stepwise approaches that we use for lipid lowering really don't make sense when you've just missed 40 years of collective cumulative exposure to cholesterol. Now, why find people early? Well, you can see basically at the bottom left-hand side, less than 3% of individuals, about 2.1% of individuals are identified before the age of 18. When you find those children, they don't have atherosclerosis. The later you leave things, as you can see on the right, with every decade of age, prevalence of hypertension, diabetes, increased BMI, they all go up. So the later you leave things, there are two things that will happen. One, you've got comorbidities and other cardiovascular risk factors, but also behavior, lifestyle, all of those things are going to be a lot harder. If you find those non-index cases, i.e. you found the index case and then you've gone and looked at siblings and so forth, the non-index cases tend to be younger. Unsurprisingly, there is less atherosclerosis, in part because of the fact that these people are younger. So again, it's moving the needle towards thinking about screening. Now, when we think about how these individuals are being managed, we've got only about 3% of people attaining LDL levels below 70 milligrams per deciliter. We see greater use of things like atorvastatin. The average dose is about 40 milligrams, rosuvastatin 24 milligrams. But you can see on the bottom, the likelihood of getting to goals increases with combination therapies. And the biggest step up that you get after statins is really the third drug, which is a PCSK9 directed therapy, and that makes sense. If most of your abnormalities in the LDL receptor, you need to make more, you need to keep them alive longer. Now, why start early in childhood? Well, this is good data from the Netherlands, which basically showed that if you look at children of parents who'd been diagnosed with FH, the parents were all diagnosed after a cardiovascular event. That led to the child being screened. So on the left-hand side, they were started on statins. So even though you see the children's levels of LDL being lowered before the age of 18, and unaffected siblings, untreated, their LDLs will go up. Because of that difference in cumulative exposure starting early, what you find is that children with FH compared to their parents over a 20-year follow-up period will hardly have cardiovascular disease. So again, suggesting that we should be moving to doing this earlier. A final word on homozygous FH. Prevalence 1 in 160,000 to 1 in 300,000. This is the global data, just under 900 cases. The average age of diagnosis globally is 12. The average LDL cholesterol is about 15 millimoles per deciliter. At the point of diagnosis, almost 1 in 10 either have aortic valve disease or have cardiovascular disease already. And importantly, in low middle income countries, the time to first event, or the age of first event, is 24 years. In high income countries, it's basically another 13 years later, 37. And largely because they are using combination therapies with 4 or more drugs. So for homozygous FH, we need to find probably these kids before the age of 6 and start to think about using 4 or more lipid-lowering therapies. So in summary, FH is way more common than we realize. It occurs in all geographical regions of the world. We need to think about screening and probably universal screening, identifying cases before the age of 18, ideally the first decade. And when we find them, we need to think about using combination therapies. Probably in children, statins and ezetimibe would suffice. If you find people late on in life, you're going to have to probably think about using a PCSK9 directed therapy as an add-on. For homozygous FH, earlier diagnosis and largely using 4 or more treatments are going to be needed. The challenge really is for us to put this into clinical practice, otherwise the prevalence detection gap is only going to widen. Thank you.